Hello and welcome to Karen's Medical Corner. I'm Karen O'Day. I'm a certified family nurse practitioner and a certified nurse midwife, owner and operator of EverCare Family Practice. I specialize in family health care, aesthetics, bioidentical hormone replacement for men and women, as well as I have a specialty in balance evaluation and vertigo evaluation. Today joining me is my husband, Jim O'Day. He's a doctor of audiology and owner and operator of Northern New Mexico Hearing and Balance in Santa Fe, New Mexico. He also has extensive specialty training in balance assessment and evaluation. And so I wanted him to join us again for this part of the topic where we're going to talk about what we see when we do the testing, as that is his specialty, and he has once again agreed to do the podcast with me as long as he is not on a video. He has an amazing radio voice, but he is quite camera shy. So I want to talk about the vestibular portion of vertigo first in diagnosis. And with this, we'll start with one of the most common reasons people are referred. It may or may not be their actual diagnosis, but we see it frequently coming over in referrals, and that is Meniere's disease. So with Meniere's disease, I will not see anything abnormal on blood work. I won't see anything abnormal on MRI or on physical exam other than vertigo, which sometimes may be elicited if they're having an issue while I'm doing the exam. So if they're in an active phase of Meniere's, they may have symptoms during the exam, but it's not specific. And so I'll always send them for audiogram, as well as VHIT, which we do in our office. We do not do V&G in our office, as that is a torturous, barbaric test that really should be laid to rest many years ago, since we do have VHIT, which is an excellent diagnostic tool and does not make people sick while you're doing it. So I'm going to turn it over to Jim so he can tell us what he finds on evaluation with audiogram and VHIT for Meniere's disease.
Hi, I'm the disembodied Jim. Anyway, what do I see? With Meniere's disease, if I did a hearing test on them, in the early stages, it would be a low-frequency sensorineural hearing loss. Now, as far as tympanometry and acoustic reflexes, those would look perfectly normal. Okay. When we have the option of doing so, and that's not always the case because we live in a rather large state where people can't come in and out quite often, but one of the early signs of Meniere's is fluctuation in the hearing loss. So because of the limitation of my field, and what do I mean by that? I mean, nobody refers to me from the typical docs because they were never trained that one of the five senses was hearing and hearing loss. I just got hit by my wife, by the way. And because of that, I don't typically have a baseline, a baseline for hearing. So what did they have 2 years ago before this started? I typically don't have that. So what we would like to do is a series of hearing tests to see whether or not there is a fluctuation in the hearing, some days better, some days poorer, and that's also a very strong sign that what we're really looking at is Meniere's disease.
And so what would you see on a VHIT if you had a low frequency loss that was fluctuating and you wanted more diagnostic criteria? What would you think that you would normally see doing a VHIT?
Well, VHIT is evaluating, by the way, that's a video head impulse test. It's a very sophisticated high-speed cameras that we place on the patient's head, and we have the patient, who's typically about 3 feet away from a wall, look at a specific dot, and the instructions are stay on that dot with your eyes. No matter what I do with your head, turn it right, left, up, down, and diagonally, please focus on that dot. Now, if the vestibular ocular reflex, which is what we're evaluating, is normal, then there would be no lag time between the head movement and the eyes staying on that particular dot. What we see, though, with damage to the semicircular canals is a lag, a slowness of that eyes catching up to the quick head movements. By the way, when I say head movements, I move their head about 2 or 3 inches. I'm not ripping it off. So it's not. It is not a cruel test by any means. And for the vast majority of people of just about all ages, I have tested people into their mid 80s. It's not difficult at all because they're just sitting and looking at a dot and relaxing while I'm behind them moving their head. They don't know which way I'm going to move their head. That's part of the test too, so that it's an involuntary head movement from my end of it, and the eyes will stay with it if everything is functioning fine. So with Meniere's, as well as other pathologies of the vestibular system, you will see a lag of that reflex.
And what about, talk a little bit about VNG, since a lot of providers still use that test. What would be expected to be seen if a VNG test was done?
Okay. The VNG is evaluating a different response. The response that we're looking for in VNG is a difference in nystagmus from both positionals and calorics. Now, what do I mean by nystagmus? When people are reporting vertigo, the outward signs of that vertigo that we see as providers is a fluttering, literally back and forth, of their eyes. And the patient perceives that as the room spinning. Okay, so when we do VNG, we're putting them through a series of positionals, right, left, back straight, and then with their head hanging over to see if there's any asymmetry between the ears of that nystagmus. If there is, that's an indication that there's a weakness on that side. Now, that part is difficult for a fair number of people that have skeletal problems. The older you get, the more stiff you are, so it can be tough. But it's nowhere near as tough as the caloric part of the test, which is why my wife considers VNG barbaric. What the caloric part is also evaluating nystagmus, but that nystagmus is being induced by either one of two different methods. One is with air, both warm and cold air, and the other is being induced by water, either again both warm and cold water. By far, the water part of it is barbaric. It produces such nystagmus that most people get sick from it, and even the air, quite a few do, especially since they're already prone to having vertigo to begin with. So, I prefer to use the VHIT because it can be used, number one, on almost everyone. I've only had one or two that just the one limitation of that test is when somebody's blind in one of their eyes, and I think I've had that twice in the years that I've been doing it. But otherwise, I haven't had a limitation, and it's a good diagnostic tool.
Thank you, Jim. The next thing that we're going to talk about, continuing with vestibular system, is something that is very common in people, and I get a lot of referrals for, and that is otoconia, where what people will tell me is they're told that they have crystals in their ears. Well, we always have crystals in our ears and in the semicircular canals, but they're usually attached to these little tiny hair follicles. When they become dislodged, they get stuck in one of the semicircular canals, like a train getting stuck in a tunnel. And that can induce vertigo. It's very difficult at times to diagnose because you have normal blood work, normal MRI. Their audiogram will be what their normal is, and that could be anything because a lot of times, like Jim said, we don't have a baseline audiogram on somebody. So they're coming in for the first time. If if they have a hearing loss, they may have always had that hearing loss, but it won't be something that looks significantly abnormal for something other than like noise exposure, or possibly, could be genetic, or presbycusis, which is age related. But that would be normal. Acoustic reflexes would be normal, as well as tympanometry. So one of the tests that I do in the office during the evaluation is called a Dix-Hallpike test. Now, I do get referrals quite often that say they've done Dix-Hallpike and it's normal, but the provider is not doing it with Frenzel lenses. If you're not having a Dix-Hallpike done with Frenzel lenses, it is impossible to get an accurate test, because when the eyes can focus and you lay somebody back, if I lay somebody back or I turn their head left to right, their eyes can focus and I don't get the nystagmus. It will correct itself. So the Dix-Hallpike Frenzel lenses actually cause the eyes to not be able to focus, so that when the person is laid back or their head is turned side to side while they're laying down, they will have nystagmus to the side that is having the problem. And that nystagmus will resolve relatively quickly, which is a sign of otoconia. If the nystagmus, which again is the eyes kind of twitching like this, does not resolve in a short amount of time, then that is not indicative of otoconia, but more of a central nervous system problem, which we'll talk about here in just a minute. I did want Jim to address another problem that we do see quite a bit, or a diagnosis that is given prior to referral, and that is labyrinthitis or vestibular neuritis. And when somebody comes in and they have a diagnosis of that, I am not able to diagnose it with physical exam. You cannot see anything on the external ear, the external ear canal, or the middle portion of the ear that is visible. That is not able to be determined. So a lot of times they are given this diagnosis, but no testing has been done. So at that point, I will send them over to Jim. He will again do audiogram with acoustic reflexes and tympanometry, and I'm going to have him tell you what he typically sees in doing those tests with diagnosis of labyrinthitis or vestibular neuritis.
Okay. Well, not to harp, which I do anyway, but this basically what we're looking at, or I should say what we're hoping for, is to see an asymmetrical hearing loss. Now, why do I say asymmetrical? Well, number one, we're truly hoping that it only hit one ear, because that sort of pathology can literally wipe out your hearing. You can be in the middle of the day, it can hit. It can hit in the morning. It can hit any time. And it is so sudden for many people. And for many people, except for the rushing noise, the feeling like you just lost everything as far as the hearing is concerned, there's no other symptoms. They don't have a head cold. They don't feel bad. It just happened. And the reason why I'm saying I would prefer they not get anything, but the reason why I say hopefully it's an asymmetric hearing loss in that it only hit one ear. I've seen both ears, one ear, and severity of loss could be anything from relatively mild to profound degrees of loss. We don't have any sort of judgment at looking at people. It can happen at all ages. I've seen it in the young. I've seen it in the very old. And it's a tough one, because in truth, we are only guessing a lot of the times that it's viral. Now, and we go from there. And then I dump them quickly back to Karen to hope that a treatment can help.
Thank you, Jim. And so I think we've covered pretty much the vestibular issues that can cause vertigo. Again, with labyrinthitis and vestibular neuritis, kind of grouped into that at the same time, can be a sudden sensory neural hearing loss. That is usually a significant drop in the hearing, and the patient will notice that immediately. Sometimes they call, sometimes they don't. It can or cannot be associated with vertigo, which is why I'm not really putting it into the vertigo topic, because many of the patients that I see with a sudden sensory neural hearing loss do not experience any vertigo whatsoever, just primarily hearing loss and ringing in that ear. So the next topic I wanted to talk about in diagnosis would be a discussion of central nervous system etiologies. So when we're looking at the central nervous system, a lot of times when we're doing an audiogram or acoustic reflexes or tympanometry, that may or may not be normal. If we're looking at something like an acoustic neuroma and we're concerned about that in relation to vertigo, many times the hearing may be off asymmetrically during the audiogram, but they also may be lacking in their acoustic reflexes, and the acoustic reflexes should be symmetrical on both sides, or absent if they have a huge degree of hearing loss, and then we can't tell anything by that. But if the acoustic reflexes are off on one side as compared to the other, then that's an indicator for an MRI. And MRI with and without contrast is how many of these central nervous system problems are primarily diagnosed, because the blood work may come back normal. Findings on physical exam may not be significant, as well as with the audiogram and balance testing, although with acoustic neuroma, which is a tumor on the 8th cranial nerve, you would see an asymmetry or an absent acoustic reflex on one side. And so with an MRI, you would see the tumor, and then treatment options would be discussed. We'll talk about that in episode 4. Another etiology that we see when we do an MRI of the brain with and without contrast can be symptoms or suspicion for Parkinson's disease. Because in Parkinson's disease, and this is why it's important to get an MRI with contrast, is that you can see neurons of the brain that are damaged. Now, that may or may not give a complete diagnosis, but that does give the ability to know how to handle this patient at this point. Other things that we see on MRI would be a history of stroke. Normally, we're not going to see something with an acute stroke. This is going to be something where they've had a stroke, and now we're seeing it on MRI with some significant changes in the white matter. And sometimes you might see a clot, but usually not. Usually it's just white matter of the brain. You'll see significant changes, and they will be able to, radiology will be able to give a diagnosis of stroke. Migraine headaches, one of the causes of vertigo, especially in women, simply because women tend to get more migraines than men, although men can have it too, it's just seen more in women, is vertiginous migraines. Now, with vertiginous migraines, that's a difficult diagnosis, and the diagnosis is a lot of times related to history. Do you have a migraine and get vertigo? Or maybe you don't have pain, but maybe you have ocular auras, or you have an aura that you're going to get a migraine. The pain never comes, but the vertigo does come. That can be one of the clues. Is obviously not a diagnosis that we just like to say, oh yeah, that's what it is, so I'll get an MRI of the brain. Sometimes not. We'll see some mild white matter hyperintensities. They look like little stars in the white matter when you're looking at them on an MRI. They're not big. They are fairly small, but we can see that. Other things that we see on MRI with people who are having vertigo in relation to diagnosis, sometimes if people do have difficulty with alcohol addiction and alcoholism, we'll see gray and white matter that is reduced in size in the cerebral cortex. And that's an indicator, that is a change that we see with the disease of alcoholism in relation to testing with the brain. I'm going to have to use some notes, and I usually don't use notes, but I have a lot of other diagnoses that are seen in blood work, and I just didn't want to miss any, so I wanted to make sure that I had written them all down. With MS, multiple sclerosis, we would see demyelination on MRI, which would be an indicator that this person may have MS, as well as other symptoms. One of the main symptoms that somebody has MS is initially they may report loss of vision in one eye. Vertigo is also associated with MS. Blood vessel disease, so related to, say, tobacco use or high blood pressure that's not been well controlled for a period of time. We will again see deep white matter hyperintensities on the MRI. Seizures usually don't cause migraines, and a lot of times with seizures we don't see anything on MRI that would be diagnostic of when the person is having an episode that they start to have symptoms of vertigo. And those are the primary things. Anterior pituitary tumor, we would see not just with MRI, but we would have an elevated prolactin level in the blood work, and then the MRI would show a tumor in the anterior pituitary gland, and that can cause vertigo as well. With several other more rare disorders, when we're doing MRI, if we see vessel changes that are associated with ocular changes, or hypo or hyperintense white matter changes, those are indicative of more rare conditions, and referral would be definitely indicated at that time. We'll talk about that later on in the disease process, but those are other things you would see during doing an MRI, or if you saw abnormalities, you might want to get an MRA of the brain to actually look at the vessels more closely. So some things that we see in blood work that can cause vertigo would be thyroid disorders. So if I'm doing thyroid testing, if they have Hashimoto's disease, their antibody levels will be high. Their levels, if with Hashimoto's or hypothyroid, would indicate an elevated thyroid stimulating hormone and low T3 and T4. With hyperthyroid, it would be low TSH and elevated T3 and T4. That's just basic information. You can do further evaluation for the thyroid, but that wouldn't be done in my office. We would discuss referral at that time, and we'll talk about that tomorrow. Doing an ANA, which is an anti-nuclear antibody screen, it can be positive falsely, especially in women who are over the age of 40, fair complected, for unknown reasons. I've had a positive ANA several times that is completely false, which is why we get the reflex analyzer, which breaks down the antibodies that we're looking for autoimmune disease. So a positive ANA may be an indicator of lupus, scleroderma, rheumatoid arthritis, Sjogren's syndrome. We get a rheumatoid factor checking for rheumatoid arthritis as well. But if we see that and those elevations are significant, then that's something that we are alerted for. Sometimes people have a positive ANA that is very mildly elevated, and that is not necessarily an indicator of a problem or the cause of the vertigo. With syphilis as well, tertiary syphilis, which means that you've had syphilis for a long period of time, not only affects the brain in an MRI, but also you would see a positive antibody test. So like I talked about yesterday, or the last second episode, is that the RPR, which is what is routinely tested for syphilis, eventually over time will go back to normal even without treatment. But the antibody test, the FTA, will stay positive. And so that's an indicator that that person would need treatment. If we're looking at the complete blood count, polycythemia vera is a cause of vertigo, and we see that when we have an elevation in red blood cell count, hemoglobin, hematocrit, and other areas of the CBC that we're looking at. Lyme disease, we can see Lyme disease changes on MRI, but one of the primary things that we look at for Lyme disease is the antibody test. We check an antibody screen, see if they are positive for Lyme disease, if they have a known exposure, or even if they don't. Some people have no known exposure and they will meet criteria for Lyme disease, and that's a significant cause of vertigo. Allergies. Sometimes people will come in and they have a lot of allergy symptoms. Sometimes people don't have a lot of allergy symptoms, but allergies can cause vertigo. We look at the CBC for that. Sometimes eosinophils will be elevated with allergies. We also look at an antibody screen, which would be looking at the immunoglobulins, which would be an IgE being elevated. And at that point, if it is elevated, we would do further testing with allergy testing and discuss that with the patient. Vitamin B12 deficiencies are very common, and one of the first signs of a B12 deficiency can be vertigo. So people have a lot of symptoms sometimes when they have B12 deficiency. They may have numbness and tingling in the extremities, difficulty sleeping, mood swings, irritability. If it's severe, they can even have hallucinations. But vertigo is a very common indicator, as well as vitamin D deficiency. So vitamin D deficiency is a little bit interesting. When I first started doing testing, normal levels for vitamin D were 30 to 100. And in fact, back in around 1998, the indicator was 40 to 100. And since that time, they've done reevaluation for whatever reasons. I have my own theories on why they've dropped the levels, but now levels for vitamin D deficiency are below 20. If you're below 20, you could have significant issues, not just with vertigo, but with fatigue, with developing osteoporosis. It's very significant. But when people start to drop their vitamin D levels, they can start to have vertigo. A good level for somebody with vitamin D is anywhere between the range of about 50 to 85. You don't want to go above 100. It is a fat-soluble vitamin, and people can become toxic. So it's really important before somebody starts to take vitamin D because they have vertigo that they get their levels checked, because they could become toxic with vitamin D if they're not deficient, and that's not the cause. High cholesterol, we always check a cholesterol panel because we know that cholesterol can narrow arteries that are supplying blood, and sometimes that can cause, even in the microvessels of the brain, deep white matter hyperintensities and cause somebody to have some vertigo, as well as other significant health issues with high cholesterol that we're not going to bring up in this discussion. And then, depending on what the labs show, then we talk about treatment options. I'll talk about treatment options in the next podcast and more specificity on what we do for treatment. But I wanted to keep these in a doable format, which is about 30 minutes or less, because there's a lot of topics. And this video is going to run about 30 minutes. But I did want to say that you can see it's necessary to break this into 4 podcasts. And this is one of the reasons that people are not diagnosed with the problem, because healthcare providers have 10 minutes with a patient. They might have 5 minutes. Maybe they have 15 minutes. A workup for vertigo takes at least an hour, and that's it on my end. And then for Jim, he's looking at 60 to 90 minutes, depending on what testing he is doing for their balance assessment. So in regards to diagnosis and treatment, that is why a lot of providers don't work up vertigo. That is why a lot of people are not properly diagnosed, as well as the fact that a lot of providers don't know what the workup is, what they're looking for, and so they do refer them, and that is fine. But it's also frustrating from a point that there's a lot of stuff that can be done in a primary care provider's office if they have time to do it. And with the healthcare system the way it is right now, most providers really do not have that kind of time. So I'll end the podcast here, and I wanted to thank everybody for joining us. I wanted to thank Kelly and Angelina, as well as John and Mary, and Kathy V, Brad, and Amanda, and everybody else who has taken time out of their day to listen to the podcast. I hope you all have a nice evening, and I wish everyone health, happiness, and the continued ability to make their own healthcare decisions. Thank you. Have a good night.